My name is Fuchsia Howard, and for this presentation, I will provide a very brief overview of our research approach and share a few of our research findings. And Penelope Hedges, one of our caregiver and patient partners, is co-presenting and will join our discussion about engaging with patient partners. This study was conducted in British Columbia, Canada, where we have universal public health care, inclusive of oncology care. And cancer care is provided through one organization which has 6 large cancer centers across the province. And this organization serves a population exceeding 5 million people. And within this organization, patient-reported outcomes are part of standard assessments. However, caregiver-reported outcomes are not. So what are caregiver-reported outcomes? Well, they're a caregiver's, so a family or a friend's, assessment of their own health status and health-related quality of life. They are not a proxy for the patient's experience and health status. In other words, a proxy for a patient-reported outcome. Caregiver-reported outcome development is in its infancy. So across the cancer trajectory, it's unknown which caregiver-reported outcomes matter most to caregivers and how and when screening for these caregiver-reported outcomes would best be done. For this particular study, we chose to focus on caregivers of colorectal cancer patients. And we did this because the colorectal cancer journey can be complex and caregiving particularly demanding. Our overall research purpose was to describe how caregiver-reported outcomes could be integrated into cancer care in a manner that meets caregivers' needs. And for today, I'll focus on one research question, which was, how can caregiver-reported outcomes be integrated into routine cancer care? We used a patient-oriented research approach, which meant that patients and caregiver partners, as well as multidisciplinary stakeholders, were involved as equal members throughout the entire research process, with the aim to apply the knowledge generated through this research to improve the healthcare systems and practices in our province, and in a manner that speaks to caregiver and patient priorities. This was a qualitative interpretive description study, which is an applied approach to doing qualitative research. We conducted in-depth semi-structured interviews, all via Zoom, owing to COVID-19, and data analysis involved constant comparative techniques, team reflexivity, ongoing team discussions, and team vetting. This was quite a large team. We had 20 team members, inclusive of 2 patient partners and 2 caregiver partners, as well as researchers, clinicians, decision makers, and trainees. Our virtual patient engagement was bolstered by having one team member who was very much responsible for communicating with and fostering the relationship with our patient partners. And this one team member hosted partner meetings to encourage peer mentorship. And we also designed materials that detailed research methodology, as well as opportunities for our patient and caregiver partners to become engaged. And you can see on the right here is an example of one of the handouts that we use to involve our patient partners. We also conducted an engagement evaluation, which was an interim and a final evaluation to assess the engagement, not just of patient partners, but of all members of our research team. And then, of course, we made some adjustments according to our interim evaluation. Very briefly, we ended up with 78 participants, inclusive of 24 caregivers, 36 patients, and 2 individuals who identified as both a patient and a caregiver. And we interviewed 16 healthcare providers. All of our interviews were done over Zoom, and we had anticipated having the majority of our interviews be dyad interviews, so the patient and the caregiver together, but quickly found out that that was not the preference of our participants, and so only ended up with 6 dyad interviews and 66 individual interviews. And so very briefly, some of the findings that I'll share with you today really revolved around the idea that caregiver invisibility shapes preferences for caregiver-reported outcomes. As well, the acknowledgement of caregivers is a necessary first step when considering how we might implement caregiver-reported outcomes. And we also found contrasting perspectives about the assessment and discussion of caregiver-reported outcomes with the patient. So I'll briefly go into these three themes. We found that caregivers, patients, healthcare providers, and the larger structure of healthcare services contributed to the invisibility of caregiving. There was this idea that everything is and should be oriented to the patient. And because of that, caregivers reported trying to hide their struggles for fear of jeopardizing patient well-being. And while caregivers were involved as members of the care team for the purpose of looking after the patient themselves, they were not necessarily considered to be in need of care themselves. In considering the context of caregiver invisibility, the priority of our participants was the acknowledgement of caregiver needs as the first step to considering assessments using caregiver-reported outcomes. And this acknowledgement by healthcare providers was considered important for a number of reasons: for validating their experiences and helping them cope, for alleviating caregiver guilt about their struggles, and encouraging caregivers to engage in self-care or to seek help when they need it. So one woman who is a caregiver for her mother said, "This, meaning cancer, does scare us, even if it doesn't scare you," meaning clinicians, "because you see this every day, 100 times a day. This is our first time dealing with this." So acknowledging that a little bit, I think, is more important than specific questions referring to caregiver-reported outcomes they could ask me. When it came to sharing with the patient caregiver-reported outcome-related information, there were some who preferred transparency or open conversations about caregiver-reported outcomes that actually included the patient. And this was considered essential for understanding, appreciating, and addressing caregiver challenges. This transparency or openness was preferred among caregiver and patients who already had this open dialogue as part of how they normally had discussions about their challenges. As one social worker shared, "When I'm talking about support for the caregiver, I try to include, where appropriate, the patient in those conversations. So it's the assessments of those needs, responding to those needs that are identified by the caregiver, and actually having the patient be aware. For some, it does matter significantly." In contrast, there were those who preferred privacy in the assessment and sharing of caregiver-reported outcomes with the patient. For caregivers, this preference arose out of a concern and guilt over burdening the patient. And for patients, this preference for privacy arose out of feeling unable to hear, appreciate, or attend to caregiver needs. For one woman who is a caregiver for her spouse, when we asked her how she would feel about her husband knowing about how she was doing through a caregiver-reported outcome, she responded, "When he was really not well and emotionally not there, he probably wouldn't have recognized it. I think even when I tried to express things to him at one point, that he didn't really recognize that I was feeling what I was feeling." And so just two conclusions and implications. The first being the ongoing acknowledgement of the work of caregiving and the challenges experienced by some is simple yet tremendously important, and it can open the door to determining the needed caregiver-reported outcomes. As well, the integration of caregiver-reported outcomes into clinical care will require careful consideration of caregiver and patient preferences regarding the assessment and disclosure of caregiver-reported outcomes. So we're now going to move on to our discussion part of our presentation, and I'm very pleased that Penelope Hedges is here to join us in our discussion. And Penelope was one of our patient and caregiver partners who's worked collaboratively on this and other projects. So welcome, Penelope.
Thank you.
And we have 3 questions that we're going to go through. Penelope, I will start with our first question, which is, what motivated you to get involved in this particular project?
Well, I've been a caregiver and patient partner for the last 15 years. And through that, I've seen how healthcare professionals relate with the patient and the caregiver. And I realized that improvements can be made. I cared for a close family member with colon cancer from 2004 to 2010. And that was my first introduction to the world of cancer. I saw that while actual healthcare was generally good, the ancillary palliative care aspects were not well supported. The caregiver is closely associated with these issues and has to try and navigate the patient's way through them. Historically, the caregiver is not acknowledged by anyone except the patient. Until this year, I was never, as a caregiver, given any acknowledgement by healthcare professionals. So I felt it was important to take part in this research, which seeks to expose to healthcare professionals the issues faced by caregivers. Caregivers don't even think about themselves at all until they're well and truly in deep. Even then, they simply cannot do anything to help themselves because it's necessary to take care of the patient. Managing the patient's medications, appointments, meals, mental health, and possibly hour-to-hour medical situation means there is really no time for yourself. Healthcare professionals have a specific job to do and maybe can't see the wood for the trees when it comes to looking at the full scope of a patient's journey. So this is where the caregivers come in.
Thank you, Penelope. And we're very grateful for your perspectives and your willingness to share your experience, especially those personal experiences. So thank you for that.
You're welcome.
So moving on to our second question then, what suggestions do you have for researchers with patients, community members, and or caregivers in the research?
I think the important thing to remember is that not all patients are the same. Generally, I find that patient and family advisors, caregivers, are type A people with a lot of internal fortitude who have coped well, either as a patient or a caregiver. So I have to remember to temper my views and comments to reflect less fortunate people who perhaps struggled through the journey. At BC Cancer, patient and family advisors are pre-interviewed by the provincial lead for patient and family engagement. We're not there to complain about our treatment, medically or otherwise. We're there to provide the patient viewpoint and suggest improvements in the system. In this particular project, we were all very clear on one aspect of the method being used when doing the research. The healthcare professionals had anticipated meeting jointly with both the patient and caregiver together to conduct their interviews. We all knew that this would not provide the data they were looking for. Patients have a sense of guilt that they're going through a phase when they can't look after themselves, and the caregiver is spending so much time and energy on looking after them. They may or may not be welcoming of the care being given. They're unlikely to have a full sense of what the caregiver is doing or going through because, of course, they're wrapped up in their own immediate health issues. On the other hand, caregivers have a sense of overwhelm, which they don't want the patient to be aware of. If the patient does not seem grateful for their attentions, they may seem resentful of the efforts being made. The patient and the caregiver sometimes have different views of the cancer journey, which may lead to one being up about things and the other being down. They will not want to jointly discuss this with an interviewer. The patient and family advisors in this project reviewed a number of interview transcripts and were able to confirm that the views expressed by the interviewees were indeed commonly held. Overall, I believe it was a very useful exercise to include us as equal partners in this research project.
Thank you, Penelope. And I will add to that and say that, I thought it was really important that we had a group of patient and caregiver partners, because what you had mentioned in terms of every patient and every caregiver is different. Having yes. a group of individuals who might represent some of that variability, I yes. thought was really important to the project. The other thing that I thought was important, and you've been involved and engaged in a couple of research projects now, and you have a lot of knowledge and expertise in how to engage in research. And so we had a range of expertise in terms of engaging with patients. Some of our patient partners, it was their first time engaging with research. And so I thought it was very helpful to have a group of individuals who could mentor each other and support each other throughout the process. Because I know engaging in research isn't easy, and it was a new thing for some individuals. So I very much appreciated your ability to mentor within that team.
Yes, and I do think, as you say, it was very helpful to have a range of people involved who were coming from different points of view, and that's very helpful. You really need to think outside your own box.
Thank you, Penelope.
Now, let me ask you, Fuchsia, how do you think including patients and caregiver partners in this project supported the ability to learn from the research?
I think first and foremost, it very much highlighted for us that although we may be thinking about developing measures and thinking about how do we implement measures that are reliable and valid in practice, that happens within the context of a relationship with healthcare providers. And that key to that relationship, especially for caregivers, is acknowledgement. An acknowledgement at every step of the way of the importance and hard work that caregivers are doing. And so that really suggested to us to sort of take a step back in terms of thinking about a measure as being part of care. It's a part of the larger spectrum of a trusting relationship with a healthcare provider. So I think that was the first point. The second, in terms of involvement of patient and caregiver partners, it really helped to cement the relevance of our findings. You know, when we were collecting data and we only had a couple of individuals who wanted to do an interview together, you know, the patient and the caregiver together, and we were like, well, how do we get more dyad interviews? And as patient partners, you said to us, no, that's not what you need to do. This is actually really important to be able to have the space for people to speak separately. And so for us, it very much highlighted the relevance of our findings. It also suggests to us that when we think about implementing interventions within healthcare, that having patient and caregiver partners along with us really will make it much more successful. You know, we want to implement things that are priority to patients and that are going to make a difference. And so having patient partners involved every step of the way helps that process happen.
It really does.
So I think that comes to the end of our discussion questions. Any further comments that you wanted to highlight, Penelope?
I think as a caregiver, the most important thing that could be done at no cost is to acknowledge the caregiver every time the healthcare professional sees them. My experience over the last year in caring for my parents, where their family doctor thanked me every time we went for a visit, and even offered to speak with me privately if I felt that was important to me. That was such a relief and felt so good. And I think all caregivers understand, you know, it's the patient is the target of everybody right now, and really don't expect a whole lot of help. But just to be acknowledged is so important.
Thank you for those concluding words, Penelope, and thank you for your huge contribution and engagement with this research.
Thank you. You're very welcome.